Assalamu alaikum, everyone. Thank you for having me. It's an honor and privilege, and I want to really thank the APPIC organizers for a valiant effort in getting, national Pakistani physicians all in one room together. It's honestly very incredible. Very tough act to follow after the two talks we had today, but whoever organized the order of the talks should be commended because they seem to just blend into each other. So my goal here is just to give you a very focused update on what sleep apnea is, how we treat it, and where we're headed. And it's important to recognize that this disease state is very heterogeneous. And the reason I want to keep it focused is because it can impact all of us. And if I went into the details, we'd be here all day. So I have no disclosures. And hopefully we'll all learn a little bit something after the talk today. So just to get everybody on the same page, obstructive sleep apnea is a treatable chronic sleep disorder, and it's usually characterized by apneas or hypopneas, which are essentially, apnea is a complete cessation of breathing during sleep, or hypopnea, which is usually a reduction in airflow, and this usually happens due to occlusion of the upper airway. Now, this has multiple downstream effects. It can cause intermittent hypoxemia, sleep fragmentation, arousals, which will eventually lead to many of the metabolic adverse effects and neurocognitive adverse effects that we've already heard today. So how prevalent is it? Some of the old cohort studies from the 80s and 90s suggested that sleep apnea was relatively common, women up to 9%, men up to 31%. Many of these studies were done without any formal polysomnographies in lab and used home sleep studies. So there was a more updated cohort study in 2015 called the HypnoLab study, which used more updated measurement and in-lab polysomnographies. And they looked to see how common moderate to severe sleep apnea was in the general unselected population. And the numbers were quite striking. And as you can see, women up to 23%, men up to 49%. So why is it so common? Risk factors for sleep apnea. One of the big ones is obviously weight. That's probably one of the biggest risk factors for sleep apnea, but also males versus especially premenopausal females. Age itself is a independent risk factor for sleep apnea. And then obviously some of the more common things that we intuitively understand, for example, enlarged upper airways, tonsils, adenoids, larger tongues, or craniofacial abnormalities, for example, in patients with trisomy 21. Certain ethnic minorities, such as East Asians, have an increased risk of sleep apnea, even without, excess weight. Endocrine disorders like acromegaly and people who smoke, and obviously things like alcohol will make sleep apnea worse as well. So the diagnosis of sleep apnea can be done through a variety of methods. In Ontario specifically, only level 1 in-lab polysomnographies are accepted, and in our other neighboring provinces like Manitoba, I know that home sleep studies are more prevalent and easily accessible, but here we are bound. 15 events per hour, it's mild. If it's over 15, it's moderate to severe. It's important to remember Ontario specifically, only level 1 in-lab polysomnographies are accepted, and in our other neighboring provinces like Manitoba, I know that home sleep studies are more prevalent and easily accessible, but here we are bound. 15 events per hour, it's mild. If it's over 15, it's moderate to severe. It's important to remember that these numbers are a little bit arbitrary and were designed to be used for research purposes and have made their way into clinical practice because we use them in our research to define sleep apnea. So other than anatomical abnormalities, we're learning more and more that there are non-anatomical causes of sleep apnea. And one of the big ones is decreased pharyngeal dilator muscle function, or the genioglossus, decreased respiratory arousal threshold. So what that basically means is that minimal respiratory disturbances trigger an arousal in certain patients, especially females. And this will cause significantly more sleep fragmentation at relatively milder sleep apnea severities. And then something called increased loop gain. This is a term we stole from the engineers. This essentially boils down to an unstable control of breathing. A prime example of this is something called Cheyne-Stokes respirations, which many of you may have heard of, where patients will go apneic, their carbon dioxide levels will go up, and then they will respond with, over ventilation or hyperventilation, drive their CO2 down, which will then lead to another apneic event. And this is considered unstable breathing patterns. So we're learning more and more that our AHI, or the apnea-hypopnea index, is a very flawed metric and does not really capture or do a good job capturing the extent or severity of the sleep apnea burden in our patients. And many of this is because, we don't really catch a lot of these different things that I pointed out here, primarily how long the actual apneic event is. Remember, 10 seconds is all you need to count one apneic event. 10 seconds versus 90-second apneic events is it's a big difference in severity, but the index will not capture that difference. The hypoxic burden is not captured, the arousal burden, heart rate variability, all of these have adverse downstream effects. So we're trying to move away from just using one metric. As we've discussed in obesity and other health conditions, targeting more personalized or creating more personalized medicine is where medicine is heading. And we're looking at endotypes, things we've already mentioned, but also looking at phenotypes. There's people who are more sleepy, there's people who have more disrupted or fragmented sleep, and then there are patients with very severe sleep apnea objectively, but have absolutely zero symptoms. And we're trying to figure out, how do we treat these patients in a more personalized manner? So some quick examples. On the left here, we have a very common sleep apnea patient, 65-year-old gentleman. He's obese. He's got high blood pressure. He's got severe sleep apnea. And then when we think about what endotype he may have, it's more of an anatomical occlusion. He's going to do well with CPAP and weight reduction. In the middle, we have a 35-year-old patient with myotonic dystrophy. His BMI is normal, and he's got some restriction, some dysphagia. And he probably has more of an endotype that fits reduced pharyngeal dilation function and a more unstable ventilatory pattern or high loop gain. And these patients are going to respond a little bit differently. CPAP is not going to be sufficient for him. He'll probably need nocturnal BiPAP or NIV, and medications like acetazolamide and even supplemental oxygen can stabilize that unstable breathing pattern. And then we have on the right side a 55-year-old woman with type 2 diabetes, restless legs. She's obese as well. She's got moderate sleep apnea, but she has, what we can find on the sleep study, a low arousal threshold. So she switches between sleep stages very rapidly and may even have a complete awakening with very minimal respiratory events. But this will cause sleep maintenance fragmentation and can cause daytime fatigue and sleepiness. Along with CPAP and weight reduction, sometimes these patients will actually respond well to a hypnotic or sedative agent to increase their arousal threshold and prevent that sleep fragmentation. So sleep apnea, along with the hypoxemia and sleep fragmentation, can also trigger significant negative intrathoracic pressure swings. And that's because when you're trying to breathe against a closed or obstructed glottis, you can generate very large negative intrathoracic pressures. And this is what, altogether really causes all these downstream adverse effects, including sleepiness, neurocognitive effects, cardiovascular disease, and even endocrinopathy like diabetes and insulin resistance. So I just want to go through a little bit of data to show why we do what we do, and try to kind of inflate our importance in the medical field. So this is a study that looked at about 5,400 patients who had various degree of sleep apnea severity, and they wanted to see what the incidence of developing high blood pressure was. And very clearly, it's evident that patients with more severe disease are much more likely to have high blood pressure. Similarly, they found similar results with looking at people with cardiovascular disease. The red lines here are showing patients with very severe sleep apnea. The most important thing to look at this is the dotted blue line. This is patients with sleep apnea who were treated with CPAP, and you find that their risk of developing fatal or non-fatal cardiovascular outcomes actually mirrored the mild sleep apnea or the controls. And similarly, in heart failure patients, they looked at patients with reduced ejection fractions who were symptomatic, so NYHA class 2 or above. And then they wanted to see which one of these patients had sleep apnea and what were their risk factors. And while some of them, the risk factors were quite, evident, such as male gender, age, and BMI, what's interesting is that if they were more symptomatic, so NYHA class 3 or 4, or had a more severe reduction in ejection fraction or atrial fibrillation, they were at higher risk of having untreated or undiagnosed sleep apnea. So this has triggered a lot of cardiologists now referring many of their patients to get sleep apnea testing and treatment. Many of you may be familiar with this landmark trial that came out in 2016. Essentially, this was a trial looking to see if CPAP actually reduced cardiovascular outcomes in patients with sleep apnea. And this was a randomized controlled trial, about 2,700 patients. And it's important to remember a few things. These patients had moderate to severe disease. They were not sleepy, so it's non-sleepy sleep apnea patients. The problem with sleep apnea studies is that we ethically cannot include patients who are sleepy because they benefit from CPAP. And so we're forced to include people who are non-sleepy, and I'll get to why that's important. So their primary composite endpoint was death from cardiovascular events, MI, stroke, hospitalizations for any kind of angina, heart failure, or TIA. And they followed these patients for about 3 to 4 years. And essentially, it was a negative study. So these patients were on CPAP, and they had absolutely no difference in cardiovascular outcomes compared to patients without CPAP. Now, this made sleep physicians pretty angry. We realized that we were giving CPAP and we were really changing nothing in these patients. So people started to obviously dig deeper and find flaws in the study. And, we found very legitimate reasons for that, for that anger. And really, there's a few important things to look for here. One, many of these patients, because they were not really sleepy, weren't very compliant with their CPAP therapy. They only used it for 3.3 hours a night, and the follow-up period was likely too short. We know that sleep apnea has cumulative effects on cardiovascular outcomes over many years. And the most important thing is this study was not very applicable to the patient population that we see in our clinics. They weren't severe. Their hypoxemia wasn't less than 80%. 2/3 were Asian, and they were non-obese. So this study, sparked a lot of controversy, and there's been subsequent several studies that have looked at various things, which we'll get to. But here I wanted to show you why sleepiness is important. So this is data from about 1,200 patients with moderate to severe sleep apnea. And essentially, if you look at the red line, the orange line, those are the patients that are excessively sleepy with sleep apnea. And they have much worse cardiovascular disease outcomes, chronic heart disease outcomes, as well as heart failure outcomes. So sleepiness, we think, is a predictor of cardiovascular outcomes in these sleep apnea patients. And many times it's those patients that I'm really pushing to start CPAP on. So excluding them may have actually contributed to the negative study. Similarly, there was another study looking at cardiovascular outcomes called the RICATSA study. This was another negative study, but the most important thing they did is they looked at a subgroup analysis, and they found that the patients who actually used CPAP for over 4 hours had positive outcomes. So again, the length of CPAP use and finding the right patient is important. Similarly, atrial fibrillation and sleep apnea have a very intimate kind of relationship. There is a significantly increased risk of sleep apnea, up to 75% in patients with underlying atrial fibrillation. Many cardiologists now automatic trigger for sleep apnea testing if there's a patient with newly diagnosed atrial fibrillation for this exact reason. But most importantly, if you're considering treatment for atrial fibrillation in the form of cardioversion or arrhythmogenic drugs, or even ablation, if the sleep apnea is not treated, the risk of recurrent atrial fibrillation is much higher in patients with untreated sleep apnea. So atrial fibrillation is a complex heterogeneous disease itself, but sleep apnea probably has a big role here. And the negative intrathoracic pressure swings, the sympathovagal activation can cause increase in size of the right atrium, right ventricle, and over many times cause a dynamic arrhythmogenic substrate to developing atrial fibrillation. And many of these patients, this accumulates over years and years of untreated sleep apnea. And we're learning more and more how important diabetes and sleep apnea relationship as well. This was a study looking at people with different degrees of sleep apnea and essentially, again, following them to see who developed diabetes. And very clearly, the patients with severe sleep apnea had a much higher increased risk of developing type 2 diabetes. And then on this line, the orange line actually now represents sleep apnea patients treated with CPAP, and their risk actually goes down to patients with mild sleep apnea. So CPAP seems to be preventative in patients to develop diabetes. So I kind of blazed through that. I wanted to stay within time. I'm just going to go over some of the treatment options that are up and coming as well. So the most important thing is weight loss is very key if patients are overweight. Exercise itself is actually an independent treatment option for sleep apnea and can reduce AHI by a mild amount as well. And positional therapy. So this is essentially, in most cases, avoiding supine sleep. Don't sleep on your back. Most people's sleep apnea is worse on their back, and that's because the jaw, tongue can kind of fall back and block the oropharynx. And there are devices like this vest this patient is wearing here that patients can purchase to prevent them from rolling over onto their back. There's some patients that just put a sock, tennis ball, something on their back that stops them from maintaining supine sleep. So CPAP, we're all pretty familiar with. That is the first line and mainstay of therapy. This will treat any kind of sleep apnea about 95% of the time. And the technology is rapidly evolving. We now have something called APAPs, or automatic positive airway pressure treatment. And these are essentially machines that have intelligent algorithms to adjust the pressures of the machines automatically without us having to really do anything. There's also something called neuromuscular electric tongue stimulators, or Excite-OSA is the company name. These guys have a tongue stimulator that you can use during the day, and it will send a electric current through the tongue and over time slowly train it to stay forward. This is more for mild sleep apnea and snoring. There's obviously mandibular advancement devices that are made by dentists. And then we have various surgical options. So UPP is quite familiar to most of us. We also have mandibular advancement surgeries. There are some surgeons in Toronto that are offering this to patients with sleep apnea. Before the advent of CPAP, one of the big treatments for very severe sleep apnea was actually tracheotomies. A end stage possibility, but I've almost never had to go that far. We also have something called hypoglossal nerve stimulation. We're having a lot of patients ask us about this. This is only available in the States, unfortunately. Canada's market, as usual, is too small. But this is essentially a surgically implanted stimulator in the chest with a lead that goes to the hypoglossal nerve. It'll detect when the tongue falls back or causes an apneic event and stimulate the nerve to move the tongue forward, and can be quite effective in the right patient population, but requires a lot of follow-up and unfortunately not available here. So you may have patients ask you about this. So up and coming medications, SGLT2 inhibitors, GLP-1 agonists are both great for weight loss and improve sleep apnea outcomes. Acetazolamide, like I said, is a stabilizer of ventilation. And then there are medications like atomoxetine, which is an SNRI, and with a combination of oxybutynin, which are being studied now with positive results in the States and also in Canada to treat sleep apnea with medication. Stimulants are our last resort if there's sleepiness and we are unable to treat any further. So I'm just going to go through this quickly. I think we only have a couple of minutes left, but this was a subgroup analysis looking at empagliflozin, a SGLT2 inhibitor. And basically what they found is that patients that were on SGLT2 inhibitors had a 52% reduction in rate of new onset sleep apnea. And this is probably through a variety of different methods, including weight loss and rostral fluid shifts that can occur at nighttime, which, as we know, SGLT2 inhibitors can have a mild diuretic effect as well. And obviously improve diabetes control. And I'm sure many of this was in the newspapers everywhere. Tirzepatide is one of the mixed GIP-GLP-1 agonists that has been now shown to not only reduce weight, but also reduce the severity of sleep apnea, and has given this company the ability to market as a sleep apnea drug. So what is the future? Really, we want to get away from a single metric measurement and move more towards personalized management of these patients. And this is what I try to do in my clinics, and really look at the patient's entire endotype and phenotype and see how I can help them best. And that's it for my talk. Happy to take any questions later. Thank you.